right, welcome to Evan the Counselor Live. I'm Evan the Counselor. Who else did you think it would be? Well, look, I am super excited to share this with you, and I am extremely grateful for Dr. Patrick Kennedy, a specialist in ADHD, who agreed to come on and give us a master class in what ADHD is. ADHD, I believe, is one of the most popular topics on the mental health side of TikTok and social media. There has been an explosion, honest to God, a movement of people who are identifying with the symptoms of this disorder. And I would say a good amount of these folks are right on that they can identify with a lot of the patterns, traits, symptoms. Now, I think a lot of times it's easy to self-diagnose, and we have to be careful of that. But a lot of people are waking up to this reality that they're not alone, that their way of experiencing the world may be different than other people. This podcast is about as close to what I would call a breakdown as anything. He dives so deep into the neuroscience, the brain structure of ADHD. And this is not just sensationalized, comedic, dancing TikTok videos. I mean, he really goes deep into the research, and I would say he's very much on the cutting edge. So I learned a lot from him. And even with my background, I had to put my thinking cap on because, you know, this was the 300 level class. So I'm really hoping you all enjoy this as much as I do. You may want to listen to it in half speed for some of it to truly get it. But I think y'all are smart people. I think you'll pick up on it. So just pay close attention, because I feel like I walked out of this conversation knowing so much more than when I came in. And I really can't say that for all the social media content I consume in mental health. This was truly an amazing experience. So I know you all are going to be interested in this, so I'm excited to share it with you. Some quick, brief updates on my end. I just hope that you shoot me an email, evan@evanthecounselor.com. Maybe one day I'll regret giving it out to everybody, but please shoot me an email and give me your feedback. And for those who reach out, who subscribe to my YouTube and my TikTok, I will send you over some free therapy guides that I do with clients. I have all sorts of different topics. People find it to be helpful. Most people, I'd say. And I'm cranking out my book, The Communication Formula. That's the running title. And I hope to have that submitted to publishers by the end of the year. And I'm giving out a free sample of the beta version. So if you're interested, shoot me that email. We'll get that over to you. I'll tell you how to get it. So without further ado, Dr. Patrick Kennedy. All right, welcome to Evan the Counselor Live. I'm Evan the Counselor. I'm super excited today to have our guest, Dr. Patrick Kennedy, who is an MD. He's a medical doctor. He's also a specialist in ADHD. And I ran into him on TikTok and saw his content and absolutely loved it, reached out to him, and he's been generous enough to connect me with different research articles, and I've learned a lot from him. So I'm super happy to have him. Dr. Patrick Kennedy, thank you so much for being on.
Absolutely. Thank you. Doing all right. Doing all right. I'm spending the day in New York, so.
You're live from New York. I could tell.
I am live from New York.
Not from New York, are you?
I'm not. I'm from Oklahoma.
Oklahoma. A little different.
Yeah, I did. I just went and geeked out. I went by Rockefeller Center, so I watched them recording the NBC Nightly News. I saw Lester Holt and Al Roker. So
that's awesome. Just walking through New York, you always see something. There's always like nostalgia too from like movies. Yeah. I've only been there once, and I was walking around like, oh, there's that from that movie, and
yeah,
too, and kind of you have an automatic nostalgia there. So it's
never been before, but it's the one big city in this in the country I hadn't been to, so I figured it was about time.
Oh, is the first time you've been? Oh, that's awesome. Yeah,
so it's a big lots of touristy stuff. So I made the rounds.
Plenty to do for sure. Well, again, thank you so much. And for everyone who's just joining, we do have the TikTok live stream going. And so again, Dr. Patrick Kennedy, he is a specialist in ADHD. So if you have any questions about ADHD, please post them and we'll get to them later. All right. So first question I usually ask people, Who are you? Who is Dr. Patrick Kennedy? What's your background? What got you here?
Sure. I'm from Oklahoma City, and I'm a family medicine physician. I graduated medical school from University of Oklahoma in 2015. I finished residency in family medicine, where I trained in Oklahoma City in 2018, and then I've been in practice for about 3 years. And I got a particular interest in ADHD probably about 2 years ago when I realized I had it, and so I hyper focused on that and tried to help do everything I could to diagnose my family of things and what I could to help. And
Yeah.
so I've just gone down that rabbit hole, and I realized that I learn best when I teach. I'm just a teacher at heart. And so as I started to teach stuff, I realized I could learn it better myself, and people like to hear what I had to say on TikTok. So that's where I am.
That's where you are. How did you realize, like 2 years ago or a couple of years ago, that you had ADHD after all this time and going through medical school?
Mhm.
You'd think you'd have an inkling or something. And what was the light bulb that went off for you?
I think for me, a lot of it was just the general misunderstanding of what ADHD is and what causes it and where it comes from. And in medicine and in medical school, we certainly talked about it somewhat. I mean, it came up, but it wasn't something we delved really into. And so I think me having a misunderstanding of what it was, and most physicians, I think, having a misunderstanding of what it is, um, kind of kept me blind to it. And I think most of what we think about in terms of diagnosing ADHD are the stereotypical things you see in little boys, and that's how we usually treat it. And actually, I went through entire family medicine residency, and I know a lot of doctors, even family physicians, who think it's not real. I have colleagues that I still work with think it's not real, who think that stimulants are extraordinarily dangerous, that we shouldn't be using them. I actually prescribed stimulant medications in residency. We had kids that would come in that kind of fit the more stereotypical mold, and I never really knew how to dose the medications. We just
Yeah.
kind of were winging it, frankly. And I decided at some point, when there were a lot of family issues going on, and was trying to rethink about psychiatry a lot. And as I was going through some of the more in-depth information on ADHD, I started to think about myself. Started to think about my son. So I have 3 kids, and
Yeah.
in good ADHD fashion, a lot of us have it in my family, including all 3 of my kids. And certainly one of the more common times that adults figure out they have it is when their child's diagnosed. And so when I realized that my son probably had it, that was when I started to ask myself that question.
Okay.
And once I asked those questions, then I went down the rabbit hole.
You went down the hyper fixated rabbit
I
hole.
did. Yep.
Do you think, having ADHD, and this will tie into questions I have, but how has it helped you in, becoming a doctor and, your professional pursuits, and how has it been a liability, if at all?
Well, I think for me, I went straight through without knowing I had it, and I never took a stimulant until I figured I had about 2 years ago. And I think that certainly it made a big impact in terms of what I was able to focus on. So I was always really good at school. I focused on that really well. And so I didn't have much of a social life outside. And so I was able to really hyper focus on school and do great in school. And then when I got into medical school, and I was planning my wedding, I realized that I wanted to focus more of my time on that. And I really kind of struggled to transition between focusing on planning a wedding and then also staying focused on school the way I wanted to. And for me, I was usually somebody who was always at the top of my class. And it's always a big jump when you get to medical school and you're not, but I still was, even after my first year of medical school. And then when I started planning my wedding, my second year, I slipped a little bit. I still graduated in the top half, but I definitely noticed there was a bit of a slip there. The other big thing is that for me, as kind of a perfectionist, I think it's certainly one of the coping skills that people have is sometimes perfectionism, and you double and triple check everything. And so there were times when I just spent way more time on something than I needed to. I would study for tests, and it would probably take me 2, 3 times longer than it really should. And I think that was one of the biggest hindrances. And as far as helping, it certainly helped me learn a lot. I will say this too: a lot of doctors actually have ADHD too, especially depending on how you diagnose it and how you think about what the specific diagnostic criteria. A lot of them wouldn't necessarily meet the DSM criteria, but actually a lot do. Particularly men do. A lot of women don't quite as much. And after I started doing this, and I started telling a lot of my colleagues about me realizing I had ADHD, actually, I was very surprised at how many male doctors basically came out the woodwork and said, "Oh yeah, actually I have ADHD too," that I know personally, that I've known for a long time.
Yeah.
And it's just like one after another, and never happened with the female physicians that I know. But I think a lot of that's still just social expectations. And so I think that certainly a lot of doctors have ADHD, and they don't realize. And actually, they're oftentimes the ones who aren't willing to admit that it exists.
Yeah. Oh, that's interesting. And I still have a whole bunch of questions based on what you just said, but I just, for a lot of us, I guess we just assume everyone knows what ADHD is. And I think everyone has, not everyone, but most people have a general sense of what it is. And especially folks who follow us on mental health, social media. I mean, it is one of the hottest topics, I would say. What is it? I know it's a broad question, but what, explaining it to a lay person, what is ADHD?
So there are lots of different directions I could go with that. So if you want to give the kind of standard official answer, so DSM criteria, you have two large domains. One is inattentiveness and one is hyperactivity and impulsivity. And there are 9 general symptoms in each area. And if for children, if they have to have 6 in each area, and for adults have to have 5 in each area. And that's how you would get diagnosed. And you can be diagnosed as either primarily inattentive type, primarily hyperactive and impulsive type, or a combination. Now, I think that definition is very specific to a certain type of people with ADHD,
yeah.
Depending on what it is you think that it is. And with that definition, then you're looking at roughly on the order of somewhere around 10% of children-ish. It depends on where you're looking. And then in adults, you're looking about 5%. Now, I think that if you kind of expand an idea of what you think ADHD is, which I try to do, the general traits on kind of a spectrum would probably be somewhere closer to like 50 to 60%. Now, that's very unofficial, and that is
really
somewhat controversial. Yeah, so I don't know. Yeah,
is it even a disorder at that point, or is that just
that's a question. That's so you get very philosophical in these questions. Is it a disorder or not? And I could ramble on this for hours, so I don't want to go too far in this, but I can talk as much as you want. But that is really the question. You get very philosophical about what is a disorder, and when should you treat it, and does it need to be treated? And I think that the other issue is that a lot of the research you look at in terms of outcomes, certainly those are based on the official DSM criteria. And I think that most people that would meet the official DSM criteria would have the worst outcomes overall. And in particular, we've seen there was retrospective data. I don't know if you've seen this about the life expectancy of people with ADHD and how much that has, how much it impacts. So you're looking at somewhere on the order of about 9 years of reduced life expectancy for a child with ADHD compared to one without, and then 13 years for adults.
13 for adults.
13 years for adults.
Now, is that because, just based on the numbers you said, it sounds like some people kind of graduate out of it, because you said 10%, or I forget the percent for kids, it was less for adults. So it sounds like some people graduate out of it, or that's the only conclusion I could draw.
Yeah, so I think that really depends on what you're using as a defining characteristic. So if you're defining something in terms of social dysfunction, then some people find coping skills to deal with what you have as a neurological underpinning, and so they don't show up so much in the in terms of dysfunction. So there are questions certainly about, people could say that do I have ADHD because I graduated, valedictorian high school, and I had highest GPA in my college graduating class, and still top half of my med school class. So do I qualify as having ADHD because of
There's no
success? So so if you define ADHD based on social, whether or not you meet social expectations, then the numbers certainly are a lot lower. But people do kind of figure out how to do that. And the other thing too, it has a lot to do, I think, so it's hard for me to fully kind of convey without like drawing pictures. I have a certain schema in my mind,
Yeah.
thinking about neuroanatomy and neurophysiology. And I can go into that if you like. But certainly, yeah, some people would say that they potentially grow out of it, depending on what your definition is. So in one definition, yeah, they grow out of it. In another definition, people don't.
For sure. And so I was, as you were saying that, I was kind of thinking of maybe like a metaphor. And is this similar to what you were saying, where let's say like a lot of people drink heavily, right? Like some people, or use drugs recreationally or pretty heavily, but not all of them have consequences from it. So can we really call those heavy drinkers alcoholics, people with substance use disorder, if they don't have consequences, yet they still have a lot of the traits? Is it something similar?
Yeah, I could say something like that. So a lot of it depends on how you define disorder too. So how you define disease. So if you think about, these are very, I've thought a lot about the philosophy of these things, philosophy of medicine.
Yeah.
And if you are defining things in terms of a mismatch with your environment, that's a big debate that goes on now. Some people say that it's not a real condition. It's really just, some people evolve a certain way, and then now there's a mismatch with the environment, which I think is certainly true. I do agree with that. But then you get in the question of, is that a disorder or is that not? And I think that one of the big philosophical questions, you start running into religious questions as well as, how should the body be? Why do we do anything in medicine? As a physician, what is my role? What am I supposed to be doing for people? If I say that my role is to save lives, last time I checked, 100% of people died. So what am I doing with my life? Why am I a doctor? And so you got to think about, what exactly am I trying to accomplish? And so, my philosophy on this largely is, if somebody feels they don't feel well and they want to feel better,
Yeah.
and they come to me and I can figure out some neurological, biological basis for what's going on, and I can make them feel better in a way that they would like, then that's what my role is. And so that's why sometimes those questions about, is it a disorder or not, I always think about, I don't really think about I don't worry about how common something is. I think about, is there something I can do about it? So for example, even look on just the cancer.org website. I mean, I'll quiz you a little bit. Like if you have males in the United States,
Mm-hmm.
what percentage of males will be diagnosed with cancer in their lifetime before they die?
Ooh.
Any kind of cancer, any at all.
30%.
Yeah, so it's in that range. So exactly right. So it's 40%.
Nice.
40%, and for women it's 38. So in those situations, you say, okay, well, that's really common. And as a multicellular organism, I would say that it's actually expected that cancer would develop. So in a way, having cancer is normal in humans.
Well, don't we all have cancer cells in our bodies at all time?
Yep. Yeah, we do. Mm-hmm. And it's just a matter of, does our immune system allow those to overgrow? And so at that point, do you want to come to me and say, Dr. Kennedye, I have cancer? And I say, oh, no, I'm sorry. I don't treat things that are common. I don't treat things that are normal. I don't treat things that happen at rates of 40%. And so sometimes you have these questions about, people argue all the time about what the rates of ADHD are, and they don't want to expand the definitions of ADHD because they don't want it to be a large number of people. And I think that's a philosophical standpoint that I just don't hold.
Well, and back to like that addiction metaphor, right? It comes to, and again, like, is addiction a disease? Is it like a disease? Right. Is it, right? For ADHD, even if it is common, is like, do these characteristics cause issues in people's lives? Now, but again, it's that double-edged sword where there are some advantages, right? So maybe it's like, do the advantages outweigh the disadvantages? Or like, if we treat ADHD, do we still have the advantages and reduce the disadvantages, right? Or does like being on a stimulant medication, does that take away some of the advantages of ADHD or the creativity? And I was going to ask that too about, some of the downsides. But
we can go over that now if you want, or we can
Yeah, what do you think about about that as far as like as for DSM criteria? I mean, these are usually negative things. These are like negative consequences where maybe some people have that structure, some people cope, and like you mentioned yourself, like it may have been a net positive for you. I mean, look where you're at now. However, maybe now that you said that you're being treated for it, I mean, I guess just using you as an example, would you say that you've maintained the positives that have gotten you to where you are, but then also stimulants or whatever it is that you're doing? Would you say that that reduces the negatives and it's all out a win?
Yeah.
Mhm.
So I think one concept too is we tend to say things are all good or all bad sometimes, and I'm
Yeah.
certainly I'm a very measured person in that. So whenever we basically, if you add something to a system, like any medication whatsoever, there's going to be effects, and some of those effects. So science doesn't tell us what our values are. Science doesn't tell us what's a good effect or a bad effect. We decide that. So when I put a medicine in your body, you take a medicine, take a pill, things happen. Some of those things you classify as good, some things you classify as bad. And whether or not you are willing to take that medication has to do with how you've classified the good things and the bad things.
Hmm.
In general, I would say that if people generally have the same values as I do in terms of medication, I think that the medication stimulants, for example, are a huge benefit, and the benefits far outweigh the risks of the medication for most people. And maybe I could concoct a hypothetical person that they don't benefit, but I think that in general the benefits highly outweigh the risks. And then my other big medication that I tend to use is a non-stimulant medication in combination with a stimulant, and I use guanfacine extended release, which is a generic for a brand name Intuniv. And then
Yeah.
uh, that is something that I think is very helpful because it can reduce some of the side effects you get with stimulants and
Mhm.
then provide additional benefits that stimulants cannot provide.
For sure. And that actually was one of my questions of
Mhm.
kind of bouncing around, but it doesn't matter. Of
Sure.
like who would be someone that wouldn't be appropriate for stimulants? Because I mean, they are powerful medications, and I know that some of them that have the word amphetamine in there, and I know that's maybe scary. And and I'll admit too that I had maybe a negative tilt or bias, and me coming from the addiction world and seeing a lot of people who do abuse them and some of the side effects. Um, yeah, that they do release, that there is maybe a reward release, maybe more for some than others.
Yeah.
That I've been like, I've changed my opinion,
Yeah.
and I'm always evolving, and I've warmed up to it a little bit more. But yeah, are there people? I guess I just asked a lot, but like, are there people who would be the person that you'd maybe think twice before a stimulant or trying other measures first?
So I think my opinion on this is quite a bit different than most people, and I think I've given a lot of thought about the nature of addiction, what exactly is it, and what causes it. And I think about it from a neurobiological perspective, and I try to look at a lot of basic science research on it, and not rely on general societal attitudes toward addiction. And so, for the most part, my default is using a stimulant in basically everybody that I think has ADHD, at least trying it, even if they have addiction. And I do prescribe slightly differently, try to be a little bit more cautious, but actually I think that many people who suffer with addiction actually probably would benefit a lot more from using stimulants. And so I treat a lot of addiction medicine. I think I mentioned before we started about I use Suboxone,
Yeah.
do try to do as much harm reduction as possible. And um, uh, oftentimes I think those are people that benefit very, very highly from stimulants. So in general, I'll tell you what a lot of physicians will shy away from. So if anybody has, they'll say, oh, you have anxiety, you can't use a stimulant. Or they say, oh, you have high blood pressure, you can't use a stimulant. Or, oh, this person has addictive tendencies. They have a history of addiction to heroin, for example, or have a history of addiction to alcohol or anything.
Yeah.
And they will say that, well, they can't handle it because these medications are addictive. And I think that there's a large misunderstanding about how addictive these medications are. And even in scientific, I'll watch lectures sometimes and people just very offhand say, oh, well, these medications are very addictive, so you have to be careful. And I found they're just not as addictive as people think they are. And what induces addiction is a very specific set of circumstances that if you are getting stimulants prescribed by a physician who knows what they're doing, that it's really not something that people are going to struggle with. And so one of my big things that I do is I try to prescribe or try to teach the residents that I teach in family medicine residency where I work. I try to teach them how to engage in good prescribing practices in ways that are helpful to people so that they find that they like the medication and that they get a big benefit from it and that they don't have side effects from it. And we can go over why I think all that if you like, or we can adjust.
Yeah, that's a really interesting perspective. And I've heard, I guess I've seen maybe a little bit of an attitude shift of, that a lot of folks with addiction, that's one of the reasons why. I mean, it's because they like, I think it's so comorbid. And now I see it more. And I mean, honestly, I think from like being on TikTok, and we'll talk about that, like I've gotten like a 6 credit education on ADHD. I mean, like all these different doctors, and it's like I've learned so much about it, and a lot of it makes sense. Like for me, I'm in the recovery community, and I just like now I see it ever. I'm like,
Oh
all
yeah.
you SOBs, it's like all you guys
Yeah.
got, like neurodivergent tendencies, and it makes so much sense. And it almost seems like in some ways it is like a harm reduction. Like it
Yeah.
almost is like a Suboxone for like, let's say people who self-medicate with like meth. Is there like, and then I was going to ask that too, is there a correlation with people who, let's say their drug of choice is stimulants and ADHD more so or not?
So I think a lot of times people's what they are getting addicted to more has to do with what's available. I think that's more so than anything. I don't think that I've not seen any data on people that have ADHD. Do they tend to prefer methamphetamine versus opioids? I don't know anything about that. I'd have to look that up. If someone has that information, I'm happy to check it out. But what I think that the so that's another area that a lot of physicians would not prescribe stimulants to. They say, well, that person has a history of meth addiction, so therefore stimulant addiction or stimulants is a bad idea. And I disagree with that. And I'll go through the reason why. So in particular, addiction is something that is mediated obviously through dopaminergic pathways. So it's basically kind of almost like a tertiary step. So you have to think things have to be mediated through an opioidergic and then followed by a dopaminergic pathway. So dopamine is involved in the pathways with reward and behavior continuation, essentially. And if you're thinking about methamphetamine, for example, methamphetamine does not work on that pathway directly. But what it does is it works on it indirectly. That's what a lot of substances do. Mm-hmm. And so what happens is as you take an opioid, for example, so the opioid system, if you activate that, will then lead to a type of pleasurable response. And then that will lead to the release of the continuing behavior on the dopamine side.
Yeah.
The stimulants, methamphetamine and amphetamine, for example, they do not work on either of those pathways. They work on a different set of pathways. So they lead to release of norepinephrine, for example, into the synapse. And so the only way that you would really develop an addiction to that would be, well, there's a couple ways you could develop addiction. Number one would be if there are significant rises in the levels of the substance, either the amphetamine or the methamphetamine, very rapidly. And then if there's a sustained level where someone develops dependence and tolerance, so again, separate concepts from addiction, which I know you're familiar with, but I can go over for everyone else too if they want. Or if you have sustained dependence and tolerance, and then you suddenly withdraw that. So if you take the substance away after a period of time, then there are negative effects that the body experiences that are unrelated to addiction. And then whenever you reuse a substance to take away the withdrawals, you teach your body, essentially, you teach your brain that taking this substance actually makes me feel better. and you just induce addiction in
It's
that.
a, it's like, sounds like more like that dependence, more of a physical dependence. Let's say
Right.
like people have chronic pain who just like, get hooked on opiates, but maybe they don't have that same, you know, concept like a holistic, you know, more classic addiction where it's like you're using to cover emotional pain, trauma, using it for all these other purposes versus just that physical
Yeah.
dependence.
So people oftentimes will compare amphetamine, for example, to methamphetamine. And certainly if you look at them in a little cartoon structure, they're very similar. And there is only,
Yeah.
the difference is a methyl group on it. So that's why I call it methamphetamine. So my undergraduate degree is in cell molecular biology. And so if you think about how these molecules attach to receptors, very small differences actually have a huge impact on their downstream effects. And so methamphetamine, when it binds those receptors, releases the catecholamines into the synapse at about a rate of 5 times compared to what you would get with amphetamines. And in particular, for something to induce addiction, you have to have a very quick stimulus response type of temporally. They have to be very, very close within 5 to 15 seconds to induce a continued behavior. So if someone injects IV methamphetamine, so you take methamphetamine, you put it into into your vein with a needle, then you're going to get very, very rapid rise in that. And it's going to go straight to the brain. You're going to have a huge release of the catecholamines. You get a big rush. You get a very large sympathetic stimulus. You feel great for a little bit at least. And that feeling great very instantly is then associated by your brain. It's like, I injected the meth and now I feel great instantly. And if that process happens between 5 to 15 seconds, then you're very likely to induce addiction in that particular pathway. And so IV meth, definitely very addictive. Amphetamine, on the other hand, is something that has a much lower release of catecholamines into the synapse. And then on top of that, if you take it orally, for example, it takes 20 minutes, 15 minutes. If you take an immediate release, 15 minutes before you get a rise in the blood concentration, before it actually gets to your brain and starts doing something. So you actually don't get that temporal association. So you don't induce addiction that way.
Well, and that's like basic behavior modification, right?
Absolutely.
You need that, like the quicker you associate the reward to the stimulus, even if it wasn't from the substance, right? If I gave you like a cracker and then, gave you some kind of rewarding stimulus after, right? That would become paired. And, the route of administration and how quickly you get it. Yeah, that was really instilled into me, in my addiction training and behavior mod. And, actually did a bunch of coursework in like autism and applied behavioral analysis. I got to learn a lot about that. But, for example, like smoking cigarettes, and I believe that like this is true, that actually was smoking something, you get the reward fastest, like through your capillaries, and then it's like shooting and then snorting, and you could see how addictive those are versus people who just even alcohol, you get like kind of a preliminary effect, and then it continues throughout. But yeah, that makes a lot of sense why that would be less addictive. And again, like I said, I had this like bias against it, and like it says amphetamine salts and this, that, and the other. And but yeah, like when I think about from addiction, like I can't think of that like I can't think of like really any cases of people who have like that was their drug of choice where they admitted to treatment whatsoever. I can't really think of anybody. When I looked at the research in Minnesota, there was like very few people. Personally, I have seen some people where let's say like they were in early recovery, it may not have been the amphetamine itself, but they did abuse it. I think I have seen people abuse it, and I think it's usually people that aren't in a great place. Maybe they're still using other substances, where they rely heavily. I do have a question, like, are there any of the meds, let's say Ritalin, Vyvanse, Adderall, is there one that is more reward producing? Like I always had in my head that like Adderall is the one that if someone is going to abuse, like that seems to be the one to do it.
I think a lot of times it depends on how we define abuse. So if we say that abuse is anything that's not prescription,
Yeah.
And that happens a lot more, but is that necessarily
Yes.
something that is harming anybody? Um, and, certainly, legally don't do that. I'm not trying to lose my license. So whatever, just do
Yeah.
how I prescribe. But, if, for example, if you've got someone who doesn't take their Adderall and they sell it in college and someone uses it so that they can study for their test,
Yeah.
that by one definition, that is abuse because it's unprescribed use. And on the other hand, is someone ending up losing their job and their families and stuff like that because they took some Adderall in
Yeah.
college? No, not really.
No.
One of the biggest issues that I would worry about, particularly in college, a lot of people will sometimes use that in combination with alcohol, for example, and that combination is something that when you're using the stimulants, your blood alcohol content can rise a lot higher, and you don't quite realize it. And so you could be at higher risk for alcohol poisoning in those situations. And it also can be something that people they feel a little more, I don't know, maybe a little more invincible than they are. So that would be one issue. Now, as far as to answer your question, as which one of those is something that's most likely to be abused, I think really it has to do with what is most available and what's frequently cheap. And I think that when people think about Adderall, it's mainly just for that reason. I think that's probably the main.
Is it it's more available?
That's really a lot of it. And so one of the things that I certainly advocate for is using longer acting versions. So that is one way to help reduce any sort of harms. But if you're, for example, if someone's prescribing an immediate release Adderall, which is mixed amphetamine salts, then if someone, it's very easy, you could crush it and do whatever you're going to do with it. And so that's one of the issues that you'd run into. So trying to avoid situations where that's the case. That being said, though, methamphetamine is oftentimes way cheaper and easier to access, especially where I'm in Oklahoma than it is to get amphetamine. To try to get some Adderall from somebody, it's kind of expensive. Per pill, it's a lot more expensive than meth would be. And meth is
just a whole other. Yeah,
yeah.
Just another level.
And the route of use is very significant. So if anytime you're taking orally, risk of addiction is so low.
Well, yeah. When you're taking it orally, I've really seen very few people. I do have one example I was going to run by, but
sure.
So but I've never seen very many people abuse an XR, extended released. When I have seen it, it is those instant release, and even thinking about Oxycontin, right? Obviously way more addictive. And I used to abuse it. And back in the day, we'd get those, in the South, those pumping, we get those 80 milligram Oxycontin, right? You could crush those things up and whoa, versus just swallowing it and doing an extended release. It doesn't have that. It's still addictive, with opiates on a different level, but, there are a lot of people who I knew, and, I think it's people grow out of this, I think it's a lot of it's high school, college kids who don't have anything better to do, but, they'll crush Adderall, snort it, right? They'll get the reward. And then they're, like you said, with drinking, it's very paired with drinking. And then they're like, oh, I could drink more. And it does become a combo. It's almost like the 1940s, housewife combo of taking amphetamines throughout the day and vacuuming, right? That stereotype, and then drinking or taking a Xanax to come down. And that is one of the downsides I've seen with some people. And it's probably because they're medicated, right? Where it's 7, 8 o'clock and they're, wide awake, and then they have a hard time sleeping. And they feel like they need to take something to come down, like a Xanax or alcohol.
Yeah. And so really, when I'm thinking about these medications, I think a lot of time about the, just the very specific brain structures that are involved. And so we can go over this too, and why I think that's certainly very helpful for using the medications. And I can tell you kind of the schema that I have in my mind, because it's certainly much different than what people typically think about. So I don't want to hijack this too early, but if you're ready to go there, I can now. Or we can
I was going to, I had that in my questions is what is the brain structure? You know, I mean, maybe make it a little layman's here.
Sure.
You know, you and I mean, we can nerd out all day. I could tell we could have some good combos, but yeah, I mean, like what makes ADHD a brain, you know, if you want to call it a disorder or a different type of brain structure, what's different in the ADHD individual versus the normie, so to say?
Yeah. So the structures. So if you think about this, so this is get very philosophical, and people get very angry because there's a lot
I
of
love it.
religion
Let's
kind of
go. Let's
overtones
get
with this.
philosophical.
But so if you look at evolutionarily, how humans developed as compared to say other animals, for example, one of the things that makes humans humans is not unique to humans 100%, but kind of is our ability to take information and then kind of hold it in mind and think about a longer term goal. So I don't know if you ever watched series on from Dr. Russell Barkley on YouTube or not, but he's got some great series. He's got great lectures on executive functions and what they are and how they help us. So if you're looking at an organism, for example, like a dog, so you can certainly do a lot of conditioning with a dog, but of course you have to do something on a very instant basis. So you have a stimulus response, stimulus response, stimulus response, and within 5 to 15 seconds. And you have to have a stimulus, and then as the organism responds to the environment, you have to have some other either pleasurable or negative um, reward or consequence that comes toward them. And that's it. That's how actually most of our brain processes information. So the vast majority, probably 99.9% of information that comes, sensory information that comes from our bodies up to our brains is processed on an automatic basis. And it's all based on this conditioning, stimulus response, stimulus response. And the parts of our brain that are significantly different than a lot of other animals is the prefrontal cortex, right up here in the front. So this is your brain that basically is you, it's your personality. It's what you do to take that information and suppress the initial responses that the rest of your brain would otherwise do, and then enact behaviors that achieve a further goal beyond the immediate present. And so when you're a baby, you don't actually have this. This part of your brain isn't very developed. You're like just like any other animal almost as a baby. And people don't like when I compare humans to animals, so that's part of what people get angry about.
I get shit for that too, but
oh yeah, we're animals.
We're animals, you know,
We're
like
animals.
okay, we're animals plus, like get
Exactly.
over it, it's fine.
And so when you're a baby, there's no concept of 10 years from now. There's no concept of a week from now. There's no concept of an hour from now. There's just the ever present. That's all that there is. And as we get older, our frontal cortices start to grow. So literally they grow back to front. They grow further, further, and further forward. And so as you get further and further forward, they're more hierarchically complex. So the structures are more complex. And the parts that are actually most complex are right behind your eyebrows. And so that's the part of your brain that is thinking about the future. And this part of your brain does not have the same type of redundancy that the rest of your brain does. And so, for example, why do people, so if you look at alcohol, you say alcohol is a depressant, and yet why do people at a low dose of alcohol become hyperactive? Well, it's because you're getting disinhibition. So the alcohol is acting on GABA receptors, it's blocking neurotransmission. But a lot of your brain and those lower structures have a lot of redundancy. So there's a lot of things like breathing. There's a lot of redundancy there. And so as the alcohol is blocking your brain's ability to function, the areas that have the least redundancy are going to be shut down first. And that's in your frontal cortex, where you have the most hierarchically complex structures with no redundancies. And so initially at low concentrations of alcohol, you're going to start to get a disinhibition. So things that you would otherwise do without your better judgment, which comes from up here, you're going to do. And so that's why people will do things that are much more impulsive and much more in the now whenever you are drunk, for example. And as you get drunker and drunker and drunker, you start to shut down more essential parts of your brain to the point that you may stop breathing, for example. And of course, hierarchically complex also includes the cerebellum. So I think it's what 3/4 of all your neurons are in the cerebellum. And so so you start to get a little wobbly, for example, when you first start to get drunk. So those are the areas that require the most neural connections to function, and those are the first that go away. And so what happens is that if you look at a stimulant medication, for example, like amphetamine, we talk about it improving your executive functions, which actually are mediated by your frontal cortex. But the stimulants don't really work there. They don't actually activate primarily in the frontal cortex. They actually activate in your basal ganglia. And there's actually one research paper that's not going to be replicated, I don't think, but it was looking at a methylphenidate, and they had radio tagged some of this. And they said, if you give methylphenidate to somebody, where does it concentrate in the brain? Concentrates in the basal ganglia. So the way I think about this in particular is that all the sensory information comes up from your body, comes up through here, and it goes through the base of your brain. And almost all of that is getting sent to your automatic processes. So things you don't even think about, they're unconscious things about, how much distension there is at centimeter 57 in your colon, for example. Like that's things that your brain's regulating and thinking about and managing all the time, regulating how full your bladder is, when you need to pee, when you need to poop, what your blood pressure is. There's a lot of sensory information. But
could that even be though, like things that are automatic? Like I always use that, like with the basal ganglia. I know it's like where a lot of habit forming happens, right? So like I form the habit of like driving a car, like where I'm not even thinking, I'm on autopilot. Whereas when I'm 16, I'm thinking like, oh God, the light, and then it becomes a natural process. I don't have to think about it, and I can sit there and daydream, and then I wind up at my destination. Is it similar to that with the automatic responses?
yeah, similar to that. So what happens is, so when you're learning things, there are certain parts of your brain that are active, and then once it's already in your system and it's on autopilot, there's other parts that are active. So whenever you're 16 years old and you're driving for the very first time, this is a new thing, and you have to plan things out. You have to think, where am I? Where am I going to be? What do I have to do? There's lots of very complicated things you've got to think about, and that's mediated by your prefrontal cortex. After you have done this, for example, for a long time, your prefrontal cortex basically kind of guides where these automatic processes and memory are going to be, how they're going to be structured. And then after a time, you no longer have to use your prefrontal cortex in order to drive, for example. You can drive and think about other things. And so, and then when you move, for example, and you have to take a different exit or take a different route, if you're not paying attention, you'll automatically go in that spot, right?
Yeah.
And so what happens with the stimulants is they work in the basal ganglia, and the basal ganglia is having 99.9% of stuff is automatic, and a very small percentage of stuff has to get shifted into your frontal cortex, where you can actually pay attention to something. Yeah. So what you're paying attention to is oftentimes very, very, it's a teeny amount of sensory information coming in. So for example, I'm sitting here talking to you. I wasn't thinking about the sound of this air conditioner previously, but my brain was processing it just the same.
Yep.
And what you have to do is look for differences between all of the background information. So which information needs to be kept in the background and which you need to think about and use this higher brain function to think about future goals. So what the stimulants do is they help the tracking of what's going on in the basal ganglia. So they get more information where it needs to go in the frontal cortex. And so if you think about from a neurobiological perspective, where does ADHD come from? If you think about, so we do know that there are differences in the dopamine receptors, and there's questions about where this came from originally, but differences in the way the brain attaches to dopamine, for example, in the basal ganglia. In particular, there's one called DR4. And if you have basically about a certain amount of stimulus down here, and for something to go to the frontal cortex has to be very different. So there's got to be kind of a difference between stimuli. So if there's a decreased difference between something that gets tracked in the prefrontal cortex, then you're going to get a lot of sensory information that you don't otherwise want in the frontal cortex there. So you're focusing on sensory things. A lot of sensory issues with ADHD and autism. And what the stimulants do is they help you track that information a little bit better.
For sure. Would you say that the prefrontal cortex is kind of like the adult in the room?
Yeah. So I always tend to call that you, and then the rest of your brain, I usually call it lizard brain. Some people don't like that, but I call it lizard brain, and there's you. And so the stimulants basically activate you. And so, for example, when you think about addiction, let's go back to addiction. So what's happening with addiction is that the way I define addiction in particular is you in your prefrontal cortex, for example, the you that's up here has recognized that there are negative consequences to some particular action, whether that's pornography or alcohol or whatever it is, or something that you don't like and you think that it's not good for you in the long-term future. But of course, your lizard brain doesn't think about the long-term future. And so for you to not do something, for you to inhibit what your lizard brain wants to do, your prefrontal cortex has to be active, has to be on, has to be paying attention. And that is where your will comes from. That's where your want to. That's where
Self-control.
Your self-control comes from. That's exactly what your
Yeah.
prefrontal cortex does. And so whenever people are dealing with addiction, for example, and we'll go into that, I've got a little bit of a kind of a heretical view on treating addiction, so we can talk about that too. But when you're dealing with this, your prefrontal cortex has to be active. And so anytime you say you have addiction to heroin, for example, so lizard brain likes heroin. Lizard brain knows that if you take heroin and you inject it in your IV, you're going to feel good. You're going to have a pleasurable response. So lizard brain likes that. So anytime you feel bad, someone's mean to you, they punish you, you got fired from your job, you had a bad day, lizard brain wants heroin. Okay, and for you not to use heroin, your frontal cortex has to say, no, heroin's not good. We're not going to use heroin. And you can have that self-control for a while, but you cannot have it 24/7 until you die. So if I have someone that comes to see me that is addicted to heroin at age 20, for example, and I say to them, you need to never use heroin again, ready, set, go. If the expectation is that failure is defined by using heroin ever, then the likelihood of failure is extraordinarily high. So since there's not as much redundancy in the prefrontal cortex, anytime you're tired, anytime you haven't eaten well, anytime you haven't slept well, the prefrontal cortex is not going to be functioning. Your brain uses a ton of energy. And so whenever you're in any of those situations, that's when people will relapse. And so I've had people, so I work in a psych hospital, I have people who deal with addiction all the time. And I always ask them, you said you were absent from alcohol for 18 months, and yet you're here now. What happened? Why did you do? And most of the time the answer that I get is, I don't know. They don't know why they did it. There's something deep inside them that makes them do it, and they don't know how to fight that. So I had one patient who told me, he said, I've been living in a halfway house, and then I lost my job. I don't know why, but I just walked straight to the liquor store. And he hadn't drunk any alcohol in 18 months, and he just walked straight there. And then he ended up
Autopilot.
Yeah, exactly. An autopilot. So he felt really bad. So what happens is, anytime you feel bad, your brain wants to feel better. And when it comes to memory, there's memory that's involved with this. And so lizard brain remembers that when you use heroin, you feel better. Because you do, because it activates those opioid receptors, which is involved with pleasure. And so you knows that that's not a good idea, and yet you do it anyway. You're able to control that whenever people are around you are nice to you, and you've been well fed, and you've been well slept. People relapse when those conditions are not present. And one of the things that
it's tired, right? Like it's those situations where the adult in the room
absolutely
it can't fight, right? It's like it's exhausted. It's it's worn out. You're not getting taken care of, and then you're just more vulnerable. And like you were saying, like I think of it, you're using these great metaphors. I kind of view the prefrontal cortex as like it's like Siegfried and Roy, right? Like they're smarter, but they're in the cage with the tiger. And if it's like they have ways of you can't control the tiger, but you can manage the tiger. And that survival, right? That's more connected with our survival instinct, the rest of our brain. So it is more powerful. Yet this is an advantage. It is smarter. And then with addiction and maybe ADHD as well, maybe that's why they're so comorbid, is that more of the energy, more of the the delegation, if you will, the Congress of the mind is on the side of that survival part. And maybe would you say is like some of the advantage? Because it's like, I think maybe there's this idea that people with ADHD are more cerebral, they're more automatic, they're more maybe intuitive in some ways.
I think it really just depends on, so the way I think about defining ADHD is, so with that structure in mind, I think about where the basal ganglia are tracking information. So I tend to think of ADHD as people, well, at least in terms of DSM criteria, people that struggle to activate that prefrontal cortex as much or as often as they want. So they have trouble regulating it essentially. So sometimes it turns on when you don't want it. It's a hyper focus.
Oh, so
And
yeah.
then, yeah, and then sometimes you can't turn on when you want to turn on. And I think it has a lot to do with a decreased difference between stimuli. So, for example, if you're not interested, the stimulus has to be really big for you to want
Yeah.
it, and it's just not right there. And if something is really, really stimulating, it's really hard to get away from it. It's hard to let this other stuff get in. So you're playing video games, for example. You have a child playing video games for 8 hours nonstop, and it's hard to you try to talk to them and they don't hear it. You talk to them and they
Yeah.
don't hear it.
You don't even
Yeah.
remember to eat or pee, when you're in that
Mhm.
hyper focus. And is
Absolutely.
that when you're in that hyper focus, are you saying that that's your prefrontal, like an overdrive?
A little bit, yeah, yeah. So in other words, that stimulus is so high that it's hard for other stimuli to get in, essentially, because it's something that's just very, very, very. So you have trouble regulating that, essentially.
So it's more of a
Um,
disorder of shifting, of like shifting
uh-huh.
gears. It's
Yeah.
like you're either in drive or reverse. And most people, it's like, oh, if I could be in reverse, and then I go to drive.
And you
But people
turn
with
it on, turn it
ADHD,
off, turn it on, turn it off. Mm-hmm.
you're 60 miles an hour. So it's kind of hard to hit the brakes and then go into reverse. If you're always 60 reverse, 60 forward, it sounds like it's a disorder of shifting in some ways.
Good metaphor. And what the stimulants do is they allow you to basically control that quite a bit better. So you can activate the front prefrontal cortex a lot more. Um, and it doesn't necessarily always help you turn it off as much, but it helps regulate a little bit, but it does help certainly activate it. And in particular, that's one of the reasons I think that using stimulants helps with addiction is because, of course, when you relapse, when's that happening? It's happening whenever your prefrontal cortex is turning off. It's not activated as much. So when you activate that, you tend to have much better self-control.
Yeah. Okay. Yeah. That makes a whole lot of sense. Just to shift gears a little bit, why is ADHD so damn popular on social media?
I think that a lot of it has to do with, I mean, I'm not an expert in social media, so I can't say from that perspective, but just my own thinking, just off the top of my head, I think that a lot has to do with people describing ways of experiencing the world that people never really described to them, and finding that that description is something that they have always felt and thought that it was just them. And there's lots of ways that I felt over the years, feeling kind of isolated and thinking that, oh, I'm the only person that thinks this way. I'm the only person that acts this way. Um, and certainly, in the last, so about 2 years ago, I realized I had ADHD, and probably about 6 months ago, I realized I'm autistic as well. So thinking about um, ways that I've always behaved in the world and
Yeah.
thinking that I'm the only one that this is like, and there's something
Yeah.
very strange about me. And then hearing somebody else that can resonate with that. But I think it required people to be able to describe a certain set of conditions for other people to recognize it. I think that's why it's particularly popular.
Yeah, and I've heard, I mean, and I think some people criticize a little bit, and I totally agree with you. I see some people criticizing, the whole ADHD talk of saying like we're taking these very normal human experiences and then clinicalizing, be like, oh, I have rejection sensitive dysphoria. Well, don't a lot of people not like rejection, or like how, is
Yeah.
there an element of that where people are, like identifying with these symptoms, but it's really may not be ADHD, it's just normal?
I think it's just philosophical questions again. How do you
Yeah.
want how do you want to view the world? So there's a great book that I read. I didn't agree with the actual conceit of the book, but I think it was very illuminating anyway. It's called Saving Normal. It's by Dr. Francis Allen. He was a psychiatrist who was in charge of creating the DSM-4. And in the DSM-4, they made a couple of expansions and diagnoses. And but he tried to be very, very rigorous in showing scientific data before they describe something um, in the DSM. And one of his conceits in the book was that most people should be normal. So he just decided philosophically, most people should be normal, irrespective
Statistically.
of anything
Yeah.
with data. He just said, I just want most people to be normal. So I want something that is considered to be abnormal, but something that exists on the fringes. So something that is a small percentage of the population. So he
On the
likes
bell curve, yeah.
on the bell curve. Yeah, exactly. He wants abnormal to be on the far reaches of
Yeah.
things. Anything in the middle should just count as normal, and we shouldn't medicalize those things. And I agree that certainly you don't want to medicalize things. If someone's happy and someone loves their life, do you want to say no, there's something wrong with you? No, I don't want to do that. But if I have somebody who's suffering already anyway, do they have to be within the top 5% of sufferers before I treat them? Or if there's something I can do to help, why can't I just do that? Now, certainly the other issue is that if you think about stimulants, if you overestimate, if you think that the risk is this high, then you say, well, you must need the worst people because the risk is so high.
Yeah.
If you think the risk is very low, then you don't need to be quite as rigorous in some of these diagnostic questions.
Yeah, I mean, and at the far tails of this, we got to go like 2 standard deviations over. Like that's a pretty high bar. Mm-hmm. So it's really funny. I have a friend who's a psychologist and he does testing, and we were talking about this, and he was saying like business is booming literally because of TikTok. He's saying that like just literally double the amount of people just because of TikTok. And I asked him like, well, how many people, like in your diagnostic opinion, like actually meet the criteria? He's like, about 50. And I mean, I don't know how.
Percent, I mean, or
yeah, just like 50% of these people who are identifying on TikTok. He's saying, about half of them, right? They're really identifying with these symptoms. It makes sense, just like you. And I could say kind of a similar experience for me, where I always knew like I had symptoms. I don't know, I'm still kind of coming to terms with like how I want to like define it for myself or whatever, but like I meet all the puzzle piece would fit very well, like everything, the way my life's set up, like how my mind works, hyper focus. I've always been like that. And I actually, myself too, from TikTok, I'm like one of those people that I'm like, like started to explore it myself and kind of test different treatments and stuff. But yeah, and I've seen people have that theory too, where it's like, well, look at TikTok and how it's set up and the dopamine rewards that you could get from that in some ways, like TikTok is almost like a flame to the moths that may have ADHD. Would you say that's something?
I think so. I think that's probably accurate. And, certainly get to think too about it. But so I have a kind of different idea when I think about, making these diagnoses. I as a physician, I think, what can I do, right? What I have a person who feels a certain way. What can I do for them? And if you think about the DSM really, it's a schema for categorizing real world presentations of people. So you have people that show up, you have 100 people that are in your office, and you notice that a lot of people tend to do things a certain particular way. They react a certain way in certain situations. And you can kind of find these clusters of symptoms, signs and symptoms that exist together. But really, that's what the DSM is. I mean, it's basically descriptions of what these things are. They don't necessarily automatically tell you what the etiology is. We have ideas and we fight about these things all the time. But what exactly is the etiology? Because the etiology is what really is going to have a big impact on how you're going to treat somebody. And so when I'm thinking about these DSM criteria are based on hyperactive boy. I mean, it's based on little boys.
Yeah.
And one of the things that I certainly think a lot about, and there's a lot of information on TikTok about this as well, is that certainly it looks very different in women, and it does. And so if you can have the same kind of biological underpinning, and depending on what society's expectations are you, you will kind of go and have different patterns of behavior. And for women, the expectations are a lot different. For some women, for example. And so what they look like as an adult is a lot different than what a little boy might look like. And so clinically, if some people walk in your office, they're going to look a lot different. And so women aren't necessarily going to meet the DSM criteria the same way. And it doesn't mean that they don't have the same kind of biological underpinning that would benefit from stimulant. And so if you are looking at the DSM criteria, you're kind of getting like just basically like a slice. It's like a subset of people that have some greater idea that we're recognizing. And I think that For example, for a psychologist who, if primarily what they're doing is um, psychological evaluations, for example, and they're
Yep.
very, more rigid in what their DSM criteria are, then yeah, you're going to get those numbers that I quoted to you earlier. But I think that what we're recognizing is that we're kind of seeing something quite a bit different. So one of the things too in family medicine, I see entire families, and I see parents, I see kids, I see moms, I see dads, I see grandparents, and for me, I just see the whole family. And so you can kind of see how these things present differently, but they all kind of have different flavors. And if you look at women, for example, the way that women look who have this kind of same underlying thing, they look the same at 18 months, at 2 years of age. And then over time, they start to morph and look a little bit differently by age 3, 4, and 5. And a lot has to do with their societal expectations of their behavior. And so for people who are not recognizing these non-social cues, for example, who have autism, I found that diagnosing ADHD is much, much easier in women who have autism because they're not adjusting their behavior nearly as much. And so they present much, much more like those classic DSM criteria. So for example, I have 3 kids, and my son, he's a lot like me. And then my older daughter is someone who, she was 3 or 4, and I was like, she's got ADHD. We already knew this. But I wanted to get her tested by a psychologist. I already knew, but like, I can't treat her myself. I can't write stimulants. That's very uncouth.
Gotta like kind of nudge the doctor, like, hey.
Yeah, and that's we talk about this too, about talking to your doctor, because I've had to a bit be on the other side. But with my daughter, I knew that I wanted to get her tested as quickly as possible because I was afraid that if things went further and she got to be 6, 7, 8 years old, she was going to look a lot different. And what I found is that for women, they just they don't look the what you expect with the DSM criteria the same way the older they get. And that shift starts to happen somewhere around 5, 6, 7, 8. Just anecdotally, where I've watched this, it just seems like to me. Whereas for boys, it doesn't always happen. Now, other times, if you has to do a lot with who your role models are too. So if you have males who have very strong female role models, they oftentimes don't meet those criteria as much either, and they tend to present with a lot more anxiety. So women show up a lot more anxiety, and a lot of men with female role models like me have a lot more anxiety. And basically, whenever people are doing things a certain way, like boys will be boys, they don't adjust their behavior as much because nobody really expects that of them, and so they tend to have those appearances of the more classic DSM criteria for ADHD.
Okay, yeah, that's fascinating. I have so many. I mean, we could get.
Yeah,
I mean, I have so many
go forever.
Well, how? Yeah, just but how much more time we got with you?
I nothing strict. I was going to try to go somewhere about 9 Eastern. So yeah, nothing strict.
Yeah, a little bit. All right, because like
a little bit.
so much. Okay. Yeah, so people are asking about, the difference between men and women, and I know that there are different societal social expectations. It's like the stereotype of the little girl, at school who's well behaved, and right, and then kind of the opposite for guys. It's like expecting you challenge authority, you kind of make your own way through life, you make your own rules. Like it's kind of more tolerated with boys, and these are just expectations that maybe are never said, but it's picked up on. So I could see how that makes sense. And, you keep coming back to this idea that the DSM criteria, which is how we diagnose, is really only hitting a small subset, right, of the little boy in school. And that's usually who is diagnosed. Now, someone had asked, and I'm curious too, I don't know, with the DSM-5, like the next version, what was it, TR, whatever it is, the next version that's going to come out, whenever that is. There's always rumors, like, do you know of changes that they propose to make? And if not, like, what would you change about it to capture more of the totality of the population who has it?
The way I think about these, I've said it a couple times already, but I think about, what's more the etiology. And I think a lot of times in psychiatry, we just don't really know what the etiology of things are. So the last 2 years, I've done a ton of thinking on this, and I have my own schema. So I'm actually thinking about writing a book and trying to explain what is in my head. And so, with the DSM, I don't have any insider knowledge. I don't know anybody that works on it. So
There's
if I had to,
rumors, it's like the iPhone coming
yeah,
out. It's like, I heard you don't know.
yeah, I've not looked into that. So I don't really know, but just knowing how these things typically work, I would not expect any wholesale changes. One of the reasons that they don't want to change, there's a lot of, talk about changing the name ADHD. They say it's not attention
Again,
deficit. Right. It's a better term probably executive function deficit disorder. So EFDD is something that Dr. Russell Barkley says. One of the reasons that it's not going to change is because a lot of protections for in terms of disability are codified under the term ADHD. So if you change the name ADHD, then you are largely disenfranchising people from those ADA protections. So that's one of the issues that you have with changing the name.
they can't just switch it and just be like, no, it's the same thing.
Yeah, I think if they write the name ADHD in the law
Yeah.
as being protected.
Yeah, exactly. What would you change? Let's say, it sounds like maybe you agree with this executive functioning disorder. And, people ask too, it used to be called ADD, then they added the ADHD. Now let's say maybe the more precise would, executive functioning disorder. And quick sidebar on that, I've seen people say this, on ADHD talk of like, that maybe it is a misconception of like the inattentive versus hyperactive, where usually both of them are going to be part of it, but the hyperactive may be more in the form of like impulsivity versus running around. Because even the DSM, it says like climbing about, can't sit in their desks, climbing trees, like.
Yeah. So a lot has to do with how people modify their behavior as they get older. So a young boy, for example, they're all over the room when they're, in kindergarten. And then by the time they get to be 20, like they can at least sit in their chair and they're just fidgeting their leg, for example. So it again has to do with societal expectations. And so when they start to realize that there are major consequences for getting out of your chair over and over and over again, they actually do adjust their behavior. And so when it comes to that, that hyperactivity, impulsivity, I think a lot of that is, if you think about, again, when are you impulsive? It's when your part of your brain is doing things based on what you want right this second, and it's not thinking about these longer term goals. So executive functions are ways of holding information in mind and then thinking about some future goal, and then shutting down what your brain would otherwise do. Your frontal cortex does this all the time. So like when babies are born, they pee on themselves, right?
Yeah.
So it's mediated through the spinal cord. So your bladder fills up, it kind of triggers a switch, and then your spinal cord will send a signal out to make you pee. Well, that never actually goes away. That's present all the time, but your frontal cortex shuts that down and makes you not pee on yourself. That's what happens. Same thing when you poop. There's a natural reflex that when you eat food, it just goes through. You call it gastrocolic
like
reflex.
People with dementia, it's like they don't forget how to do that, like they.
Yeah, a lot of things, as your frontal cortex goes away, a lot of those things come back. So, for example, a lot of your primitive reflexes, there's some that we learn about in medicine you watch. I say newborns as well. And there's certain ones you check for and they go away at a certain period of time. These are things that are mediated automatically, particularly by the spinal cord. And as you get older, these will start to go away because the frontal cortex shuts those down. Well, if you get a stroke in your frontal cortex, they come back. And so that's what your brain's doing, shutting those things down. So as you start to find that there are consequences for certain actions, you start to adjust your behavior as a result. And so you will see, so for example, in the DSM criteria, when I'm doing evaluations in adult men, I might say, okay, do you ever feel like you can't sit down in a meeting? And they're like, oh, I can sit down in a meeting. Right. Like, do you want to get up? And they're like, yes, I want to get up really, really bad. I can't sit in this meeting. It's horrible. And I'm suffering and I can't focus on the meeting, but at least they're sitting there. Whereas if they were in kindergarten, they would just get up. So at some point, that's something that people oftentimes learn not to do.
So, okay, on one end, it's a learned behavior. And I want to throw this, from my own personal experience, where I think that's why nobody noticed. I've always been like really chill. Like people always see me as like a super chill, laid back guy. I'm not running about, as a kid, and I'm certainly, climb trees and stuff. But I was a little more quiet. I wasn't, I wasn't like, I was a little more introverted, when I was younger. But like even today, people just view me as this super chill guy. But like in my head, though, I'm like, my mind is going like 100 miles an hour. I'm just not here. I'm just in
Yeah.
my own world running around in trees. And like even right now, like I just picked up a deck of cards and I'm sitting here like, fidgeting with it. For me, like that really like helps me focus. But I could also be very impulsive, right? Like I can make really quick decisions that aren't always the most forward thinking. I have a hard time like controlling impulses. So maybe that's that hyperactivity where I'm not running about, but it's maybe more up here,
Yeah.
right?
Mhm.
Does that make sense, or is
No,
that?
it makes sense. So a lot of people will describe things that way. And one thing that I kind of help people think about, especially when I use a medication called guanfacine, it helps with impulsivity a bit more than the focus. With impulsivity, so we often think of impulsivity as doing an action outwardly that we can see, but actually it's fairly impulsive to not do something at all, to have
Yeah.
an automatic gut reaction to not
Yeah.
act. And that's
Okay.
how I always was. I was a kid. I didn't move. I mean, I sat still. I was quiet. I didn't spout my mouth off all the time because my gut reaction, and I would impulsively would be to just zip it, and then I have to think about it a lot, ruminate until I would find that it has that threshold for me to actually say something out loud. So that's one pattern that you'll see, and women certainly tend to have this pattern a lot more. And so whenever you are outwardly kind of shutting down your behaviors, you can still be impulsively shutting those down very quickly without even actually thinking about it. And then you can then be thinking about these things ad infinitum, um, as you are trying to process. And in this process, can be very distressed, and it tends to activate your fight or flight response a lot. And people are really really anxious. Um, and so this is certainly something that I have a big disagreement with. You think about psychologists, they say, well, you don't have ADHD. You actually, it looks like ADHD, but it's your anxiety that is mimicking the ADHD. And I certainly disagree with that. They said you can't focus because you're anxious. And I think, well, maybe, maybe they're related on that, on the initial side, and the anxiety is just one way that some people present. So I
Yeah.
think of anxiety as sympathetic nervous system stimulation with a negative connotation.
Yeah. And where does, and I've heard this, like, well, for one with ADHD, I mean, it seems to be so comorbid with just about every other mental health disorder. I've heard, yeah, depression, anxiety, bipolar, addiction is one of the really big ones. What is there a relationship? And I don't know if this is a misconception, where it's like, a lot of people who are diagnosed with ADHD, it looks similar because they've had trauma. Is
Mm-hmm.
that, is that an actual thing where like a lot of kids who like grow up and have developmental trauma, some of those ACEs, the adverse childhood experiences at home, parents aren't there, whatever, fill in the blank of childhood trauma, that they exhibit more of those hyperactive symptoms in school. What's the relationship there with trauma? Is that still ADHD? Can that cause ADHD like symptoms?
So my thought on this, this is a little bit kind of this is just me speaking off the cuff, things I've thought about a lot. So it's none is official. It's nothing you're gonna find in
This
a
is
place.
all new territory. I mean, a lot of this stuff is
Yeah,
kind of on the
this is how I'm
cusp,
like really really rethinking this thing. So what I think about is, I think of basically PTSD
Yeah.
is a memory. Okay, it's memory. And so when you think about memory and emotion are intrinsically linked, they're stuck together. So when you make a memory, your emotions that were present at the time of that memory are part of the memory. So when you recall the memory, those emotions come back. So if you have a traumatic experience, then as that traumatic experience is encoded in the memory, which memory is very fallible, by the way, and very corruptible. Every time you recall a memory, you can actually change it just when you recall it. It's kind of like a file on your computer. Every time you open it, you can adjust it a little bit before you save it again
Yeah.
and put it back.
Yeah.
But there's emotions that are attached to it, and we have this, whether it's a good emotion or a bad emotion. If it's a good emotion, we call it warm fuzzy. So someone thinks about when their child was born, they feel good all of a sudden as they recall the memory. It's because the emotions attached to that memory. You think about a happy day like a wedding. You feel good, for example, it's because that good feeling is attached to the memory. And whenever it's a negative emotion, we tend to call that PTSD. Now, historically and classically, we call PTSD based like the huge things. You come back from war, the shell shock, someone died. And that is just like at the very far extremes of what you're experiencing. And so as they're recalling the memory of watching somebody else die, for example, that fear of death comes back. All the sounds, the sights, the smells, they're all all that sensor information is encoded in the memory, and they all come back flooding with it. And that sympathetic nervous system response of anxiety, that fight or flight system, comes back along with that memory whenever you recall it. And so it doesn't have to be that very, very strong, like worst case scenario. You tend to have a lot of these micro PTSD. So very, very small things happen to you all the time. And they happen repeatedly over and over and over again from the time that you're a baby all the way until you're older. And so I think this is really what people think of when they talk about the term chronic or complex PTSD, the CPTSD. I think that's really what that is. It's basically all these a lot of these teeny tiny things that have developed over the years that have led you to behave in a certain way that tend to cause you to react with significant anxiety. So what I think about when in terms of ADHD is that ADHD increases the likelihood that you're going to develop PTSD, for example, and these tiny micro PTSDs, partly because it leads to higher emotionality. So whenever you're more emotional, the memories tend to stick better. So anything that has an emotional component, you remember it much better.
Someone with ADHD then is just more susceptible to having those trauma reactions in response to the adverse experiences, is what you're saying.
And they're more likely to have the traumatic experiences in general as well. So what are some common examples of traumatic experiences? One, could be being a victim of domestic violence, for example, sexual abuse, neglect. Well, what are those types of things that occur in people who have ADHD if you're a parent and you are struggling to control your own emotions, for example, you have emotional dysregulation, you're more likely to lash out and physically beat your child. You're more likely, people with ADHD with impulsivity, more likely to engage in sexual abuse of children, for example. They are more likely to have issues with their own problems, and the child is more likely to be neglected in those scenarios. So sometimes we start with a person and we say, okay, what are all the bad stuff that happened to you in your life? And we kind of start from that aspect. So, you have trauma, so that's why you have all these things. And certainly the trauma has a big impact on all your feelings now. It certainly does. But sometimes we kind of forget that the environment that you're existing in is not in a vacuum. You're born into an environment. Since this is very highly genetic, then a lot of oftentimes both your parents have it, or a bunch of other family members have it as well. And so when people have those,
what's the genetic? I'm sorry to interrupt, but what is the?
So these numbers are hard to pin down. It depends on how you define things.
Is there a connection?
Oh, absolutely, yeah. So if you look at, for me, if I'm thinking of that broader definition of, and some people have used the term variable attention stimulus trait, so VAST, which is a controversial term in and of itself for lots of reasons we can get into. But I actually am kind of in favor of that particular kind of idea that there are people, 50 to 60% of the population, who have certain, a mix of polygenic traits that predispose them to these ideas. And so if you're looking at official DSM criteria, I never memorize these numbers because I don't think they're super helpful, but I think it's something along the order. You have both parents have ADHD. It's like an 8 times likelihood that the child has ADHD. And the numbers are a little bit different if you have just your mom with ADHD or just your dad with ADHD. But the other thing too, for example, let's see, it's very, very common for people with ADHD to have, to get pregnant for their first child around, I think it's like four times as likely before the age of 19. It kind of took close to home because both of my parents were 19 when they had me. And in those scenarios, you get people that are more likely to end up in foster care, for example. So a lot of times people will say, well, I have all this trauma from being in the foster system. Well, think about this. Why are you in the foster system in the first place? A lot of times because of those a lot of
That
those
makes sense.
familial likelihoods of having ADHD, and they have a lot of executive dysfunction in the world. They got pregnant. They weren't thinking about long-term effects. They got pregnant when they weren't necessarily planning to, and they decided that they would have their either they may officially give up for adoption, or they just didn't take care of the child, and they just ended up in foster system anyway, or they were taken away. So, for example, if you've got parents who develop addiction, and they got both the parent addicted to meth, and they got a baby in the house, and the parents are high on meth, and they're just neglecting the baby, and then the police bust in, they take the baby away from this dangerous environment, put them in the foster system, and then yeah, you would have a lot of children in the foster system that have ADHD. So when I work in the psych hospital, there's lots of children there, and I see them all the time. I treat their medical issues. They've got lots of sensory issues, and lots of impulsivity issues. In fact, a lot of the children that I see are actually they're themselves as sexual transgressors. We have units for that, where they were in the foster system and they sexually molested their foster sibling, or the neighbor, or their biological sibling. And a lot of these kids have ADHD. I would certainly diagnose them that way, and yet they're not on medications for that, because they say that they have all these symptoms that mimic ADHD because of all the trauma they've had. And I think, if you really just treated them for ADHD with a stimulant and a non-stimulant in combination, you probably would get a lot better treatments than using these antipsychotic medications, which is pretty common.
Oh yeah. Well, yeah, I mean, it makes so much sense. It sounds so much like alcoholism or drug addiction, like that same cycle where the kid is more likely, is it a learned behavior, is it genetic, okay, both, but then they have more trauma, therefore they're more likely to have alcoholism. And then with ADHD, I mean, like you said, I mean, I think there's such a strong, like having that, quote, neurodivergent brain in people with addictions. When I sit in like a 12-step meeting or something and I just listen to people talk and their life, it's just like, God, there's got to be more of a correlation than when we even, are
Mhm.
is common knowledge at this point. Yeah, wow, yeah, that makes so much sense, and I could see how that cycle perpetuates itself. And uh, so I have a question. So the another like narrative that's out there that I've heard before, something like, all right, you go to somewhere like France where the kids are disciplined and they eat good food, and they don't play as many video, whatever, you don't see ADHD, you don't see the rates of ADHD in France, and they don't need to be on stimulants as kids. And you kind of hear these narratives. Like,
Yeah.
what's your thought on that? I don't know if that's even true. Maybe in France they do, but kind of this conception that ADHD, it's less about biology and it's more of just about the American lifestyle or how we parent, how our society is structured.
So, if you're thinking about this from the neurobiological perspective, in terms of literally just genes,
Yeah.
certainly your parenting is not going to change your genes. There's epigenetics, so there are some effects on that, but in general, no. I mean, there's no good evidence to suggest that your parenting causes this, that watching video games causes this. Nothing like that. I think a lot of it has to do with what are those societal expectations, and what are people looking for, right? So, if you go back to the United States 100 years ago, 150 years ago, I mean, you could say that, well, we don't have a problem. We just kind of ignored these issues, but we don't have PTSD, we don't have depression, we don't have things. These things aren't real, right? So it has a lot to do with what you're trying to see, and what you define as normal, what you define as abnormal, and a lot of those are just socially mediated issues. I think in terms of nutrition, I think that certainly nutrition does play a big role in helping with ADHD and depressive type symptoms, because your brain uses a lot of energy. You're in an adult, probably about 20% of all the calories you use in a day is consumed by your brain. And so and the other thing is your brain tends to really prefer glucose. And when it comes to, so exercise is certainly extremely important. So you think about this, and this is something that's a totally other topic we could maybe touch on another time, but humans evolved in a scenario in which we walked every day looking for food.
Yeah.
And in terms of regulating your energy and where it goes, so for example, like why do we have a fight or flight system and a rest and digest system? Why do we have the sympathetic and parasympathetic nervous systems? It's basically a way of shifting and saving resources because you don't need a certain amount of blood volume fighting and run away all the time, and you don't need blood volume digesting your food all the time. So you basically shift it back and forth.
Well, maybe
and so
with habits, right? When they become, it takes less of your brain functioning. That's why we learn.
Yeah.
In some ways too, it takes less, so we could focus that laser that we have that could only kind of go that prefrontal. We could use that for other things versus the automatic. Is it similar to that, like what you're saying?
A little bit similar to that, yeah. And I think, for example, like if you are, well, this is kind of complicated in the weeds, but your brain just needs energy all the time, so it doesn't really have a good mechanism for calling and asking for energy, right? Your muscles do. So if you start running, your muscles are good at calling for energy. And they use insulin they're insulin responsive. Your brain is not. So your brain is largely just relying, because it needs energy all the time. Our brains are largely evolved to rely on our muscles and our movement to call for energy, to release glucose out your blood system. So if I go run, for example, that'll stimulate my liver to produce glucose from glycogen, for example. And if you are sedentary and not moving, then your brain doesn't really have a great way of calling for those energy stores. And since your brain uses a ton of calories all the time nonstop, the areas that are going to struggle the most are the areas that are they don't have the most redundancy. So that prefrontal cortex is not going to work nearly as well. So that's why when you're tired, when you haven't slept well, when you haven't eaten well, it's really hard to think critically and think really tough. And so movement is extraordinarily important. Exercise, not great long-term for losing weight, but it's great for mood and your ability to focus and your attention.
So yeah, well, I was going to ask that too, because, like we're so, the primary intervention for ADHD, and this is something I didn't understand too as a clinician, where I'm less medication focused, right? Where it's like every other disorder, we try to be conservative with meds, right? It's like, hey, we're not going to start on an antidepressant until we try these other things first, right? It's like not that bad to be an antidepressant, but there's some side effects. You don't know how you're going to react, and then you have to remember to take this pill every day, and then essentially maybe take it for the rest of your life. So it's like, hey, can we change some things in your environment? But I never saw that with ADHD. It just always seemed like, I mean, I guess you have disorders like schizophrenia, where I'm not like, all right, we're going to try exercise, but
Sure.
first, or like, really severe bipolar or something. I guess why is that, or or what are the behavioral things that you do have control of that maybe aren't medication focused, ways to manage your ADHD? Maybe you just do the behavioral with medications that you would recommend that actually show some benefit for ADHD symptoms.
I think that a lot of this is more philosophical questions. I think it has to do with how likely do you think a medication is to be beneficial? How likely do you think a medication is to be harmful? What's the risk benefit profile of those? And then where is your personal cutoff on when the line is crossed to start with medication? I think there's just historical reasons why we tend to think about medications first. But I think that, I certainly, when it comes to stimulants, I'm a big advocate for using the medications first off. Number one, because a lot of the behavioral interventions that we talk about with ADHD, they're great, by the way, they're wonderful, and you should be using those. But what they're doing is you're trying, so in particular, you do things that are cognitive behavioral techniques. You find these behavioral things that are meant to find ways that you can learn how to utilize your prefrontal cortex a little bit better. And yet, if you are not giving yourself if you're not stimulating that part of the brain as much as you would like to, then it's hard to make those things stick. So I think about this in terms of, I made a video once kind of comparing this to glasses. So, if you have trouble reading, I can do all kinds of interventions and say, here's how you should read. And, let's talk about sounding out the letters. And let's talk about this, that, and the other. But, if you literally can't see the words because you've got a refractive area in your eyes, it's really probably best if you get someone with glasses first, and then you do all the rest of that other stuff. And so that's kind of how I view ADHD medication. All those behavioral interventions are extraordinarily helpful and important, but they're much more effective if you start with a stimulant. And then there's other things you can do on the backside. The stimulant is not something that automatically makes your life better, frankly. What it does is it activates your prefrontal cortex. And for someone who's never used it before in the same way, now you've got a lot of learning to do. I mean, starting a stimulant is just the first step. It's something that you've done it. Now it's time to do all the other hard work.
Behavioral. Oh, okay. So it's got kind of that prerequisite.
Yeah. That's how I think about it.
Makes sense. I mean, do you, and you're talking about your kids, I mean, what's too young to be on a stimulant? Is there too young? Like, and I mean, you're taking, this is something theoretical, you're taking the rest of your life. Yeah, I don't know. It just rubs people the wrong way. And even myself, I'm just thinking like,
yeah,
it's an amphetamine, you're putting it in, like, now they're going to be on it forever. Like,
yeah.
there's just something, and it may just be, that an emotional reaction versus like a logical, like, but that just feels weird to a lot of people. Like, what would you say is like the youngest, and is there considerations? And
in my opinion, certainly a lot different than a lot of doctors. So the standard, I'll just say the AAP's recommendations. So American Academy of Pediatrics would suggest that a lot of times they would say it's hard to make a diagnosis before, say age 4. For my own kids, I knew that I tried to call an office, and most of them wouldn't even diagnose my kids until they were like 5 or 6. I got my daughter in at age 4, and that was the absolute youngest that they would do it. The AAP recommends that you do behavior modifications only first at age 4 and 5, and then as a first line recommendation, and then only consider stimulants in more severe cases. And then, maybe then you would say start medications at age 6 as a first line. That's the AAP recommendation.
So for your daughter, I mean, this is putting your money where your mouth is too. I mean, because you're doing this for your kids, even yourself, that's like a higher degree of, putting your money where your mouth is. So would you be okay with giving your 4-year-old daughter stimulants?
Yep. And I did. I did. She's 5 now, but yeah, I started when she was 4. But that's a tough road to climb too, because, the pediatrician that we go to is someone who has just all the standard, she has the standard lines that I was taught when I was in residency, the same things that I said to people. It's the guidelines I follow. But to answer your other question, I think, honestly, my personal opinion is that as soon as possible, as soon as you can think that you can safely dose it and make sure the dose isn't too high. So basically, as soon as a child can communicate to you, or that they have enough outward communication skills that you can recognize that a dose is too high, that's when I would start. And the reason I say it is this. We have seen it's not diagnostic, but we do know that for example, people with ADHD, there are certain regions of the brain that are smaller. There are regions that exist in the prefrontal cortex and that track all the way back to the basal ganglia, and then include the cerebellum. So you've got the right globus pallidus, part of the vermis of the cerebellum is smaller, and the right putamen, and the right dorsolateral prefrontal cortex. Those are all areas that can be smaller in people with ADHD. And it's not diagnostic because it's not consistent across everybody. But if you look at people who have already been diagnosed with ADHD, you will find that those areas on function MRI or on MRI are smaller. And so then the question is, why is that? And the question is there something inherent about those regions that don't develop? And I don't think so. So if you follow these over time, what you'll see is that children with ADHD have these areas that are smaller in general. They do oftentimes grow to the quote unquote normal size as people get older, but oftentimes the function doesn't appear the same way that you would expect it to.
Could ADHD actually help with your brain development? Like if you for early intervention?
I think that's what I think. This is hypothetical. This is me kind of brainstorming, but
Sure.
it makes sense to me. And the reason for this is because, so I compare this to another area in medicine. So I do family medicine. So there's a condition called strabismus, so basically lazy eye. So your eyes have to be looking at the same thing. There's two different signals from each eye. Well, if the eyes are looking different directions, you get totally different signals. So as it goes back to the part of your brain that controls that, your brain has to suppress one of those signals, and children can become functionally blind in one of the eyes because they favor one over the other. So even though there's nothing wrong with the eye structure itself, it made a signal. The way that your brain processes it makes you functionally blind. It's called amblyopia. And the sooner that you start patching on the eye, and the sooner you get corrective eye muscle surgery, the less likelihood that you're going to have permanent amblyopia, permanent cortical blindness. And these things will start to settle in by the age 6, 7, and 8. And what happens is basically you have area, and you'll see this. There's actually research looking at the occipital cortex, which controls your vision. You have differences in the thickness of the cortex, for example.
Sure.
And so what I'm thinking happens in those areas of the brain that are smaller in people with ADHD is they're just not being stimulated because you don't have the same amount of information being tracked from the basal ganglia up to the prefrontal cortex. Those areas can't develop as well. So what happens is over time, actually, there's about a 30% delay in that growth. So it will grow over time, but it's usually about 30% delayed. And then eventually it may catch up in size. And what I think is going on is that there's just abnormal tracking of sensory information from the basal ganglia up to the prefrontal cortex. So if you start the stimulants earlier and you track that earlier, you probably would develop your executive functions better because you are developing that part of the brain better.
Yeah, and it's not, and maybe a conventional wisdom or something, or just like
right.
one's thought would be like, well, are you giving them a crutch? And you're
right.
saying it's kind of the opposite. It's like you're, giving them stimulants, just like, let's say I gave a kid opiates or something from the time they were young. Well, now their ability to produce opiates or, fight off pain would be diminished because, but then there's also the opposite. And you're saying that with brain development. So yeah, that does make a lot of sense. All right, a couple of rapid fire questions and we'll let you go because
Sure.
we could nerd out on this forever. So real quick, why are you on TikTok? How did that happen?
I started a bunch of lip sync videos and I hyper focused on that, and I
The
would
lip
sing.
syncing videos?
I'm really good at lip syncing. Yeah,
Really?
I'm really good. Oh yeah, yeah. But people don't love that as much as ADHD stuff. So
we got to find.
And I spend way too much time lip syncing. Yeah, so I don't do it as much.
So a lot of videos are in your car. Why is
that?
Yeah.
Only time I get to myself. Part of it is if I'm at work, they don't, when I first started, I got talked to about about that sort of stuff. I made one or two. I made one in my office, and someone you wouldn't know. There was no patient information, but
yeah,
they didn't like me doing that. So that's why my car a lot of times, and then my house is too loud with my kids. So
for sure. Okay. With testing, what is the best way to get tested? Is it sitting there, with the little button? I actually did this one where I was, you hit the button every time the thing hits the top and not the bottom. Is that better? Or is it just literally looking at the symptoms and the Connor, test that you give to teachers and parents and stuff? What do you think the best, in your opinion, is the best way to get an accurate diagnosis?
I think that this is a controversial area as well. I'm not a fan of the specific neuropsych tests, like the pushing the button and card sorting tests and stuff. I don't like those. Those look at very specific areas of executive function, but they don't necessarily sometimes. But there's actually research looking and showing that people would otherwise be diagnosed with ADHD are being dismissed as having ADHD because they pass those tests. People with ADHD typically, on average, do less well on those tests, but that's it's kind of a bad logic to kind of go the opposite direction. So I prefer clinical interview. You look at kind of think about what ADHD is, what symptoms you have, and that's my preferred way of diagnosing that.
For sure. Yeah, that makes total sense. And like as I'm learning more about it, I've been finding, and I don't like officially diagnose people this way, but I usually refer them like it's like a vibe, right? I mean, it's like a
Uh-huh.
different type of brain
You just feel
structure.
it.
And
You
sometimes
feel
just
it.
like hearing them tell a story, it's like they tell it in like backward tree branches and then like eventually make it the other. And I'm like, okay, it's like, I'll pick on something like that. Or someone who like, I send them the paperwork for therapy, or I'm doing like an in-depth chemical health assessment, and they just like will not do the paperwork, or they like have a hard time figuring, and they're kind of all over the place. The way they set their life up, the way they think about things, and sometimes it is like the positive thing. Like sometimes, how intuitive and the way they think about problems and hyper focus, and like even just like hearing you like go just so deep into these topics and be so, it's like there's certain things like that where it's not a perfect diagnostic system, but I just pick up on that, and I'm like,
Yeah.
and I've gotten people diagnosed that way just by being like, I just, you're just one of those people, right? Like I could feel it,
Yeah.
there's an energy, there's a vibe.
Once you see it, you can't unsee it. And
Yeah.
so whenever I see patients, usually I don't really have a lot of patients that come to me asking about ADHD diagnosis. I'm kind of in an unusual position. They come to me for other things, and there's a lot of things that I pick up on that just really tip me off. And I'm actually one time, hey, we need an evaluation for this, even though I already kind of know. I go through the motions and I test them all this stuff, and I try to show them. I try to do in a very formal evaluation, but
Yeah.
I mean, I already kind of know, which again, then you can certainly criticize me and say, well, you're just confirming what you already were biased to think. And that's certainly a fair criticism. But certainly once you see it, you can't unsee it. And
Yep.
so
Yep.
there's lots of things medically. There's certainly people that no show all the time, don't fill out paperwork appropriately. There are certain injuries that happen a lot. So people, boxers fractures, people punch walls. They break, when you punch walls, you have to break this bone or this bone. If I see that, automatic ADHD evaluation. People that have trouble. So I have patients that have horrible outcomes. I have patients with type 1 diabetes, and they have really bad complications because they don't show up. They're not thinking about long term, right? So
Yeah.
diabetes is a long term problem, and that's a big issue. So I have patients that are blind with type 1 diabetes and they have ADHD. I've got patients that are on dialysis at a very young age. They have horrible outcomes with other chronic medical issues, which is a whole other topic. But if you have children who oftentimes have any broken bone, a lot of orthopedic issues, those are big ones. But punching the wall,
Yeah.
that's a very common
Yeah.
one.
There's just, these little, it's like whenever I start getting frustrated with someone on
Oh
like,
yeah,
like the paperwork or like just certain thing, I'm just like, oh, it's kind of like with like borderline personality disorder and some of the other ones where there's just these like little tip off indicators. It is, I mean, it's all a pattern. I mean, we're all unique, but we're all humans, and there are these patterns that exist, and almost like categories that we can more identify with or fit into. So yeah, and again, I can't unsee it now that I've learned all this shit. And it's weird to
yeah.
say on TikTok, but for like legit people like you and other people who have the disorder, and then like kind of self-discovery of having the brain structure like that, it is hard to unsee it. And like, and so, I'm so around addiction, people with SUDs, substance use disorders, and now I can't unsee it. I'm like, just half you, 75% of you all who are sitting in this meeting, and right, I mean, so many people struggle with substances at some point in their life, but the people who are sitting in 12-step meetings, right, these are people who have really, I mean, no one wants to be there, right? So they've really struggled, and I mean, they've gotten to the point where like, I just can't do anything, right? And they're really severe, and so it's like I just see so much of that. um two resources, one or two resources that you recommend for someone who wants to learn more about ADHD, thinks they may have it, or someone who has it and wants to learn more.
I hesitate sometimes on those because there are resources that I use, but I kind of evaluate information a little bit differently. I think there's some good information on attitudemag.com, although there's a lot of articles I've read there that are not good and that I do not recommend. And so that's kind of tricky. There are some resources. There's CHADD.
Someone asked if you went to I didn't know they were talking about, but someone had asked, or like,
ADAC as well.
have you been to a Chad conference? I didn't know if they were joking, like a Chad bro or something.
Chad, bro. No, I've never been to one. No, I would like to, but really, when I started learning this stuff, it was the beginning of the pandemic. So
CHADD. Yeah.
yeah, CHADD, and there's CHADAC or a CADAC. It's CADACC. I think that's a Canadian
Someone said
organization.
ADDA. Is that one too? ADDA?
I don't know.
That one?
That's one thing too. I'm really not up. I don't know a lot of the resources that exist. People ask me all the time, where can I get evaluated? Where can I do that? I'm like,
Yeah, I'm not
I
good
don't
with
know.
that either. People are like, what are resources? I don't know.
Like
I don't
me,
know
come
how
to
I know all
me,
this.
but I don't
Yeah.
know.
It's like, I
I
don't
can
know
only
how I
do so
know this.
much.
I don't know. I just know this. I
As
don't know
many people
how.
as like, yeah, I just know it. It's one of those things where like, what's a resource? What's your cite your sources? I'm like, I don't know. I read it sometime at some point. I don't know. It's there somewhere.
I asked you once, you said Dr. Amen, and I see him now. Is that who you're
Oh,
referring to?
no, that wouldn't have been me. No.
No?
I've seen Dr. Amen stuff and I'm not a fan.
Okay, I thought you said that. Who was it you sent me research? You said like kind of like they're your mentor or someone you learned a lot
Oh,
from.
William Dodson.
Maybe that's Dotson. Okay.
William Dodson. He was a psychiatrist that based out of Denver. He's retired now, but he had an ADHD practice. He sent me basically all of his resources that he had, which was
Yeah,
amazing.
send me
I
some
learned a lot from that.
some good resources. Yeah, definitely the 300 level class, but I like that.
Oh, for sure. Yeah. Yeah. Dr. Amen's a very, a lot of people always message me, what do you think about this doctor? And I have to I don't know most of them. I look them up, but I've
Yeah,
looked at Dr. Amen stuff and I'm not a fan of that. I'll,
for sure. I don't know
I
why I got that in my head. I think I just saw him on TikTok, started following him, and just
mm-hmm.
maybe I kind of crossed
He's
my
a
brain with that.
controversial figure for sure.
Yeah, well, I see all these other people on TikTok who are like talking smack. All right, well, I know you got to get going. Where can we find you? What do we need to take away? How do we
Well,
get more of you in our life?
yeah. So on TikTok, if I ever decide to make videos again, because I've just been busy, so I need part of it too. Is I
You'll
think
be
of a video I
back.
want to make, and I'll be back. I'm not
You'll
officially
come
gone.
back.
I'll always come back. Yeah, I make a video and I edit it way too long, so that's part of the problem. I'll make more. So TikTok, it's Dr. Was it? It's Patrick Kennedy, MD.
Kennedy
And
with a DYE at the
yeah,
end.
PatrickKennedy, MD.
And I'll
And
put this on the YouTube. And I'll put the
you can put
link
that
to
on
the
there. And
podcast. We'll
still,
get you linked to.
yeah, hashtag all my videos with my old username. It's DJPJMD on TikTok. So you can find that there. I do have a YouTube that I don't put anything on there. I will at some point. So you can
You want a
follow me.
blank YouTube?
I got a blank YouTube.
Coming soon.
People follow me on it. They do now. I've got followers on there. I've got followers on Instagram,
Yeah.
which I'm not very active on. I made it after TikTok. But one of these, probably next year, I'll make a practice, I think, and I'll hire somebody to keep that stuff up better. So if you follow me now, you'll see it in a year when I have more stuff on there.
For sure. Well, that's awesome. Well, hey, thanks so much for coming on. I really appreciate it. That was awesome. I mean, we could talk for hours. We may have to have a round two one day.
I think we should. So I was going to talk to you. We can take a note. I talked to you about Sinclair method. I want to talk to you about that. So if you're familiar with that, or if you're not, I'd say look it up.
Yeah, if you want to. Yeah, I mean,
well, we can skip it for now, but I'll
next
just
time
throw that out there. Yeah. So look it up, and you can tell me what your impressions are. It's a controversial thing as well.
Okay, for sure. Well, hey, thanks so much. I really appreciate you being on.
Okay, thank you.